Good morning. My name is Molly Thomas, nurse practitioner here at Nebraska Medicine in the Cancer Survivorship Program. So looking forward to talking with you and giving you a nice update on what is secondary cancer and why does it matter to me, to my patient, or to my loved one. I'm hoping that you'll be able to discern the difference between secondary cancer and cancer recurrence. Who might be at risk for secondary cancer? What are we talking about here? Post-treatment screening recommendations and how they're different than the general population for cancer screenings. And also we're going to talk resources and management strategies and tangible things for your patients or your loved one to go home with to know how they can decrease their risk for secondary cancer. So you may recognize the faces on the screen here. Good Morning America anchor Robin Roberts had breast cancer in 2007, and unfortunately 5 years later had a second cancer of MDS, or myelodysplastic syndrome, which is a blood cancer. Supreme Court Justice Ruth Bader Ginsburg was diagnosed with colon cancer in 1999, and unfortunately had a second cancer 10 years later, pancreas cancer. So I won't do too many charts today, but I do like to bring up, why does this matter? Why are we talking about this? So what we know from this graph is the number of cancer survivors and the age. The number of cancer survivors is getting higher as the years go by, and the age is also getting higher. And so, in 1975, there were just over 3.5 million cancer survivors living in the United States. Just as of 3 years ago, we saw that number rise almost to 17 million. And we predict in 2040 that there may be more than 26 million cancer survivors in the United States. And the reason for this is because what you've heard your doctors say in the TV commercials on personalized medicine, and we are getting to a place where patients live much longer and do very well after a diagnosis of cancer. But we do know there are some chronic things that need to be followed up on after cancer treatment, and risk for second cancer is one of those very important things. So let's just do a quick discussion about what is the difference between cancer recurrence and second cancer. So cancer recurrence may be something you're familiar with. So cancer recurrence is the same type of cancer that a person had before that comes back. So depending on the cancer type, surveillance for cancer recurrence may be indicated. Maybe it's with imaging or blood work or visits with your doctors. It's generally why we follow up here in the Cancer Center for 5 years or more as we're surveilling for cancer coming back. Now, how is this different from second cancer? Second cancer means the treatment for cancer that you had for one cancer carries a risk for a new cancer unrelated to any previous cancer diagnosis. So by now you might be asking yourself, am I at risk? Are my patients at risk? What should I be looking out for? Now, one of the top things we're looking out for is high doses of radiation. And so specifically abdominal or pelvic radiation. So specifically higher than 20 gray is the total dose. So patients that are getting higher than 20 gray of abdominal or pelvic radiation on the solid tumor side are testicular cancer patients, cervical, endometrial. So these are female cancers, also colon cancer, pancreas cancer, liver cancer, external beam for prostate cancer, which is very common, and sarcoma and bladder. So why does this matter? It just means that we're seeing much higher risk for colorectal cancer after having had, let's say, testicular cancer and getting radiation for that. So for that reason, NCCN recommends that we start colon cancer screening at age 30 or 5 years after the radiation has ended. Skin cancer, you're going to see this theme a lot. Definitely higher risk for skin cancer after having had radiation. NCCN says to consider annual full body skin exam. I do a lot of referrals over to the dermatology appointment. A primary care provider can also absolutely do this. You may have to ask for it specifically, but either way, it's completely fine. I also tell patients, have your partner have a look at your back before you get in the shower. Know about the ABCDs of moles and changes to report, such as asymmetry, border, color, diameter. If any of these things change in these moles that you have in your skin, that's important to tell your doctor about. From the blood cancer side, Hodgkin's lymphoma comes with high doses of radiation if it's diagnosed in the abdominal pelvic area, and also need to be screening for these things after treatment's complete. How about radiation to other parts of the body? So Dr. Aquazina is speaking at the same time I am about secondary cancer risk in children. So the Children's Oncology Guidelines are a little bit different from NCCN. Do reference her talk for more information about this. Something just to know, though, is breast MRI may be indicated to add to an annual mammogram starting at a younger age after radiation. So also after chest radiation, there's skin cancer risk again. So annual full body skin exam to catch that early, get it taken off and cured and taken care of. Sun safety is very important after cancer treatment. So wide brimmed hat, long sleeves, seek shade, especially between 10 and 4. Seek a sunscreen bottle that says broad spectrum on it, certainly higher than 30. Technically, the sunscreen bottle will tell you, and the recommendation is to reapply that sunscreen every 80 minutes. I have a hard time with that recommendation, but it is worth saying. There's also SPF clothing and hats that you can get in the sporting stores as well. So it's also important to report signs and symptoms of soft tissue sarcoma, which might be lumps or bumps in any of the soft tissues around your body, or pain, things like unintentional weight loss, fevers, recurrent infections, these type of things. Lung cancer is higher risk after chest radiation. So reporting signs and symptoms of unintentional weight loss, coughing up blood, voice hoarseness, recurrent infections, these types of things, fevers, a lot more fatigue than usual, shortness of breath, dyspnea exertion, these type of things. It absolutely is worth discussing the importance of tobacco cessation in cancer survivors. If you are a nurse or a provider, it's absolutely worth your time. We are the most trusted physician in nursing to talk with your patients about tobacco cessation. I like to use the term, when's the last time you had a tobacco product? Even if you're not ready today to quit, here's the quit line, 1-800-QUIT-NOW. Our tax dollars are paying for these programs in Nebraska, so I do refer to these programs and put a smart phrase in the after visit summary. Lung cancer screening is available here. In the last few years, it has been opened up to a lot more patients availability. So asking about what your risk is. And if you'd like to talk about quitting, even if you don't want to talk about quitting today, certainly seek resources, ask for help. We're here to help you with that. We do have a wonderful tobacco cessation clinic, and these programs will be growing here in Nebraska Medicine soon. Radiation to the extremities. We do see a higher risk for skin cancer and sarcomas in those as well. So how about radiation to the cranium? We see more meningiomas and also skin cancers. So there you're seeing it again, annual full body skin exam and sun safety after cancer treatment's over is important. Head and neck radiation. So some of you, either as patients or nurses or caregivers, may be familiar with a situation such as this. You've had head or neck radiation. We do see quite a few secondary cancer risks after this, which it's okay. We can screen for it and catch it early. So an annual head and neck exam is important, and referral to ear, nose, and throat doctor as indicated. Meeting your patient or your caregiver or your loved one where they are with tobacco cessation, and also asking about alcohol use. We know with COVID, these numbers have gone up. The number of drinks per day and this type of thing have gone up. And just meeting your patients where they are, or if you're drinking alcohol, ask for help. We can talk a little bit more about that. We do know that any amount of alcohol now increases your risk for 6 different kinds of cancer. So just something to kind of consider. Thyroid cancer is higher risk, so an annual thyroid exam is very important, either in your survivorship clinic or with your primary care doctor. Salivary gland cancer and soft tissue sarcomas. And we would regularly screen with imaging there, but NCCN does say imaging is clinically indicated. So maybe you or your loved one had stem cell transplant, or you were a nurse in stem cell transplant. What should we be talking to our patients about? Screening tests after we've gotten through some of the acute treatments. So skin cancer, certainly higher risk. Another blood cancer like MDS or acute leukemia are certainly possible, Liver cancer is higher risk, and oral or mouth cancer are higher risk in this regard. So we do recommend an annual CBC, which likely our patients are getting anyway, but it's important to discuss this. Also adhering to age-appropriate cancer screening. So this means getting back on board with that annual mammogram, screening colonoscopy. After an allogeneic transplant, we generally would say wait at least 2 years to get back into that screening colonoscopy, but eventually that will be important for the stem cell transplant population, and there's that annual full body scanning exam. It is important to note here that chronic graft versus host disease may increase risk of certain secondary cancers. So if your patient is still on immunosuppression after 3 months, 6 months, a year, we would consider that chronic GVHD, which those lines are blurred some, but certainly higher risk for several different secondary cancers in that regard as well. Sun safety is very important, even after treatment is over, and regular dental visits. So screening for those oral cancers is important as well. We've talked enough about radiation. How about, what if I didn't have radiation, but I had chemotherapy, I had tamoxifen, or immune therapy? So we know that 2 chemotherapy types, maybe more, are associated with second cancer risk. Alkylating agents, especially in the stem cell transplant population, higher doses of busulfan, Cytoxan, procarbazine, lomustine, ifosfamide. If any of these sound familiar to you, we know there is an increased risk of another leukemia with those medicines. What annual CBC is what we would do to screen for that. Alkylating agents also come with a risk for bladder cancer, and so a urine cytology as indicated is what, but certainly it's important for a patient to report if you have blood in your urine or pain with urination or other changes like this, where you stop urinating and things like this. Certainly the risk for bladder cancer increases if an alkylating agent is given in combination with pelvic radiation. And how about tamoxifen? This one's quite common. 1 in 8 women will have breast cancer. This one comes with an increased risk for uterine cancer, and certainly even higher risk in the postmenopausal population. So it's very important for women on tamoxifen to report any new vaginal pain or bleeding. And we as providers or nurses would refer to gynecology for transvaginal ultrasound and biopsy, looking for this possibility for uterine cancers. And PARP inhibitors. So the indications for PARP inhibitors are growing. They're indicated in more than 4 cancer types, specifically ovarian cancer, pancreas cancer, metastatic breast, and others, prostate cancer as well. We do see patients are on the PARP inhibitors long term. We do see a higher risk for these blood cancer scans. So the MDS and the AML, you might remember Robin Roberts, for example, who had the breast cancer first and then had leukemia. So CBC annually is important in that regard. So changing to a different subject here, what we're looking at is hereditary risk for cancer and second cancers. So this is a little bit of a different subject. 5 to 10% of cancers are passed down in families. So 90 to 95% of cancers are not passed down in families, but if you have been given a diagnosis or you have many family members in your family that have had cancer before, especially before the age of 50, multiple on the same side of the family, think breast, ovarian, pancreas, melanoma, prostate, colorectal, many others, please tell your doctor. Ask for a visit or a discussion with a genetic counselor to find out if you qualify for genetic testing. If you've been given a diagnosis, maybe you've heard of BRCA1 and 2. This is the Angelina Jolie or other hereditary cancer risk. Certainly high risk for one cancer and also much higher risk than the general population for a second, third, or maybe even more cancers. So BRCA1 and 2 are part of this hereditary breast and ovarian cancer syndrome. Also the other moderate risk genes, maybe you've heard of ATM, PALB2, CHEK2, many others are much higher risk than the general population for breast cancer, but also a second, third, or fourth cancer, including ovarian, pancreas, prostate, melanoma, and maybe more as time goes on. So the way that these screenings differ from the general population, we start breast cancer screening much earlier. We would add or offer the addition of a breast MRI alternating with mammograms starting at a much earlier age. Ovarian cancer, we can screen and certainly recommend having ovaries taken out after completion of childbearing. If you have a family history of pancreas cancer, we do offer, and the NCCN guidelines would recommend screening for pancreas cancer. Prostate cancer, screening recommendations change, as do melanoma. So one more genetic cancer risk syndrome. You may have heard of Henry Lynch right here in Omaha at Creighton University. Lynch syndrome is quite common. One in maybe 370 or so people walking around out on the street have Lynch syndrome. These families certainly have much higher risk than the general population for at least 9 different kinds of cancer. And so colorectal being the highest. So this changes management completely, that we would start colorectal cancer screening much earlier than the general population, sometimes at age 25 or 30, and do that every 1 to 2 years for their lifetime. Endometrial cancer screening is different. We offer endometrial biopsy screening. Ovarian cancer, there's a discussion about screening for that. Also, kidney, ureter cancer, gastric, small bowel, pancreas, liver, prostate, brain, and skin cancer. And so all come with cancer screening recommendations that are different and more vigorous than the general population. So you're saying, wow, these are a lot of risks. What can I do? So follow-up is very important. Ask your provider for a survivorship care plan. Your survivorship care plan will include your health screenings, your cancer screenings. Ask your doctor what these are. What am I supposed to be doing after I'm done? How about mammogram, colorectal screening, prostate, and others? So you can decrease your risk for secondary cancer. It's absolutely possible. If you remember nothing else, please visit this website, American Institute for Cancer Research. It's wonderful. Some themes to think about here is that getting help and assistance in a kind, non-biased environment to help you to get to and maintain a healthy weight will decrease your risk for 12 different kinds of cancer or second cancers that are associated with having extra weight on the body. We've got a very cool clinical trial opening here soon. It's a health coaching clinical trial from a mind, body, soul approach with regular follow-ups to help men and women get to and maintain a healthy weight after cancer. Our ultimate goal for movement is 30 minutes most days of the week of sweaty and breathless exercise or moderate intensity, we might say. That might take 9 or 12 months or more. Ask a very low threshold for asking your doctor or for physical therapy. At least getting up and out of the chair once every hour is absolutely a great place to start. Give yourself a lot of grace. You've been through a lot, the fatigue and the tiredness and the pain. There's so much that comes along with cancer treatment, but the more you can get out of bed and have your shower and get dressed and have a little bit of physical activity or movement. Maybe it's pumping your ankles up and down or a couple cans of chicken soup up over your head. These things will absolutely help you stay healthy during and after treatment. Let's go into nutrition here in just a minute. Limiting red meat and processed meat, sugar sweetened drinks, and following all of your doctor's recommendations. Tobacco cessation is at the bottom there. So just a kind reminder about the new American plate, and what we're now recommending is that 50% of the plate, or your goal to shoot for, is 50% of your plate be covered in 4 different colors, fruits and or vegetables. So, and a quarter of the plate be a lean meat like chicken, fish, or turkey, and the other quarter of the plate being a whole grain, like the tricolor quinoa seen here. Maybe it's a whole wheat pasta, brown rice. These are some goals to shoot for, and certainly just adding 1 more fruit or vegetable that's right for you and something that you enjoy is a really great place to start. Add 1 more handful or half cup every day for the next 2 weeks is a good place to start. We know that food fights cancer, fights risk for second cancer. So depending on your situation, maybe you've had esophagitis or mouth sores or mucositis, or maybe you have nausea, vomiting, or there are certainly barriers to eating healthy foods and fiber-rich foods. Maybe you've had colorectal surgery and we're not recommending fiber-rich foods yet. That's okay. Ask to talk to our dietitian. Her services are free. We will get you through active treatment. And then also, as we go into more of a maintenance type phase after active treatment, making sure that you know kind of what the nutrition recommendations are for you. During active treatment, we're absolutely saying we don't want you to lose a lot of weight. Eat what you can to tolerate treatment and get through and have the protein and calories that you need to stay strong and tolerate the treatment. After you're finished with your active treatment, our tune changes a little bit, and that absolutely we don't have a lot of unintentional weight loss, but we do want to help you focus on a little bit of protein, a little bit of a fruit or vegetable every couple hours to help maintain those healthy weights. So orange in color, like I mentioned, are some themes to think about here. Berries, all the berries around here, frozen is just as good as fresh, maybe even better. Dark green leafies, I know that grapefruit is limited with many medicines, so that's usually a no-go. Apples are here, asparagus is still in season, whole grains, nuts. There may be barriers one way or another, but please ask to discuss these with our dietitian. So one more step you can take, go to the AICR.org website. You can take a quick health check right here, put in some of these things, and it'll give you very specific personalized recommendations just for you. So another thing to mention here is we have a number of support services available to you here at Nebraska Medicine, whether you're a patient here or not, or a nurse here or not, or a caregiver here or not. You can certainly ask to be seen in our survivorship clinic or look up on our website that I've listed here. We have our survivorship program, cancer risk and prevention, which is the hereditary risk that I mentioned. Our psychology team are fantastic, and you can see patients via telehealth in both Nebraska and Iowa and other states as well. Physical occupational certified lymphedema physical therapist. That program is growing, is fairly robust here now. Social work, financial counselors. You'll hear Dr. Tenner talk about financial toxicity of treatment. We're here for you in this regard. Speech therapy after head and neck treatment. Speech therapy is very important, and that is available for you here and others. I mentioned our nicotine dependence clinic, and we also have very robust non-surgical and surgical weight loss options here at Nebraska Medicine. So this brings me to the end of my talk. I'm hopeful this was helpful to you, that you learned something new. Certainly contact us. I've listed my name, Rachel's name, who's the director of our program, and also Amanda Bond, who joined us recently. And you can certainly call with a self-referral at the number below.